Nystagmus, everybody's favorite topic, right? So the real title of this talk is here. Okay. So what are we going to do in this next 50 minutes? We'll go over some definitions about nystagmus. We're going to do a very brief review of eye movement systems, and we're going to do it briefly because we have a whole nother talk on supranuclear disorders. We'll talk about the history and examine these patients, trying to distinguish peripheral from central causes of nystagmus. A little bit on positional vertigo. We're not going to do infantile or congenital nystagmus, which I think you get covered in the PEDS talks, I think. And then we're going to mainly go over forms of nystagmus in neurology that have localizing value in the nervous system. So how do we define nystagmus? It's a rhythmic, repetitive oscillation of the eyes. It could be physiologic or it could be pathologic. And it's physiologic when you have a response to environmental stimuli. Something stimulates your vestibular system, or you change your body position, you're riding on a train, you're going into space. Those are physiologic causes of nystagmus. And then there are pathologic causes. So you could have central nervous system disease, peripheral vestibular disease, or in visual loss, we sometimes get nystagmus. When we talk about the nystagmus that we're looking at in the patient, we want to say, is it symmetric? So if it is, it's called conjugate. Is it going in different directions? It's disconjugate or dissociated. And sometimes it's so asymmetric that it's monocular. And an example of that might be spasmus nutans that you see in children. How do we define the direction of a jerk nystagmus? We define it by the fast phase. Even though the defect, the problem is the slow phase, and the fast phase is just a correction, we define it by the fast phase direction. So we could say it beats left, right, up, or down. So if we look at this tracing, the red on white tracing, and let's say that's vertical, you see a slow upward phase and a more rapid down phase. So this would then be downbeat nystagmus, even though the abnormality is the drift upward. If it's torsional, so that it doesn't go right, left, up, down, but it's just rotating, we can call it clockwise or counterclockwise, which can get confusing because you don't know whether you're talking about the patients or the examiner. And so it may be preferable to say it beats towards the patient's right shoulder or left shoulder, which is a little less ambiguous. If you have a combination of a vertical and horizontal nystagmus, then it may take on a pattern that could be circular, if the vertical and horizontal are in phase, elliptical or oblique if they're out of phase. So a complicated nystagmus like that, which is typically pendular, could be circular, elliptical, or oblique. A jerk nystagmus, as we said, has a slow phase and a fast phase as at the top. Pendular nystagmus, which is less common, has only slow phases. So if it's slow to the right, it's slow to the left. If it's slow up, it's slow down. And so it's hard to say a direction. You don't have a direction. You just know if it's horizontal, vertical, or both. Now, in some situations, there's a combination of jerk and pendular nystagmus. And that's something we see in congenital or infantile nystagmus frequently. Again, we're not going to cover that today. So what causes nystagmus? It's a defect in one of the slow eye movement systems. We have a lot of slow eye movement systems: vestibular, pursuit, optokinetic, neural integrator. They all have different purposes, and if you have a defect and there's an imbalance in any of these systems, the eye will slowly drift off, and in most cases the brain will say, "Where did the world go? I didn't move anything." And there'll be a corrective rapid saccade in the other direction. And that's the fast phase. So these are the slow eye movement systems, which we'll talk about briefly. And the first question is, why do we have eye movements? Why don't we just turn our head? Well, in order to maintain images steady on the retina to preserve our visual acuity, we have to have our eyes focused in a very narrow space, because the visual acuity, even a few degrees off fixation, is very poor. So if you're 20/15 or 20/20 in the center, you go out a few degrees, you're already down to 2100, 2200. And it's only the central foveal vision that's really clear. So if we did have our eyes move away from center even a little bit, we would have very blurred vision. So even walking, or even our heart beating, which makes slight movements, would cause us to be very blurred. So we need these systems to keep the eye on the prize, to see where you want to look. And we have systems that maintain steady fixation when an object is not moving, and we have systems that follow moving objects. So to hold the eye steady, we have the visual fixation system, the vestibular system, the optokinetic system, and the neural integrator. So if you're not moving and the object's not moving and you just want to look at an object, you've got the visual fixation system, which begins in the occipital lobe. But if your head is moving and you want to keep your eyes focused, you need to have something that balances the head movement, and that's the vestibular system. And through the reflex called the vestibulo-ocular reflex, you can maintain fixation, as this patient is doing here. We won't go into the anatomic details since we have a whole nother talk on supranuclear. Let's say your head's moving faster, you're on a train. Or let's say you've been doing it long enough and you've saturated your vestibular system, you need another system to take over, and that's the optokinetic system. And that takes over for sustained head rotation. And so when an object is moving farther or you're moving faster, you need to add the optokinetic system to the vestibular system. Let's say you want to look to the side and keep your eyes to the side. There are these viscoelastic forces that try to bring the eye back to the center, to the primary position. To overcome that, you need to have a system that knows how much neural stimulation the lateral rectus gets on one side, the medial on the other, to keep the eyes off to the side. And that's called the neural integrator. And that is located in the medial vestibular nucleus and nucleus prepositus hypoglossi for horizontal movements, and it's in the interstitial nucleus of Cajal for vertical movements. Let's say the target's moving. We have to be able to follow a moving target. We make smooth pursuit movements. If we have a target moving closer or further from us, we have to make vergence movements. So smooth pursuit follows a moving target up to 40 degrees per second. If you're looking to the right, it's controlled in the right side of the brain at the temporoparieto-occipital junction with some input from other places. If we want to look at something moving away from us or closer to us, we have our vergence systems. We have convergence to keep an object moving when it's closer, and divergence when it's moving further. And we all see patients almost every day with a convergence or a divergence insufficiency and double vision. So the pathway for vergence is occipital to the midbrain for convergence and occipital to the pons for divergence. Now, any of these systems that move the eye slowly can be defective and cause nystagmus. How can we tell which system is involved? Well, you really can't if you're just doing an eye exam, but if you did an eye movement recording, you could tell by the waveform of the slow wave what system is to blame. So if it's a linear slow wave, so the velocity is the same from the beginning to the end of the slow phase, that's a vestibular issue. If it's a decreasing slow phase, like here, that's the neural integrator. If it's an increasing slow phase, so that as time goes on it gets faster, that's typical of a pursuit system abnormality, and that's seen in congenital nystagmus. So much for the slow eye movement systems. We'll just briefly say that there's a saccadic system. Saccades are rapid eye movements, which moves an eye rapidly to focus on an eccentric object of interest. So if you want to look to the side and you're not following a moving object, you can't make a smooth pursuit movement. You have to be able to follow something. But if you want to look all the way to something on the side, you make a rapid movement called a saccade. It's also the eye movement that resets the eyes during nystagmus, whether it be physiologic or pathologic. And the control of saccades is many places in the brain, mainly the frontal eye fields. And for all these eye movements, whether they be slow or rapid, there's the adaptive control so that if there's a deficit in the system or if there's a change in the environment, the cerebellum, vestibular cerebellum, and others kick in. Oh, it wants me to join Xfinity Wi-Fi. And we're back. Okay. So much for the underlying physiology. Again, maybe I can shut Wi-Fi here for a moment. I don't want to get out of PowerPoint, so we'll just keep doing this. Okay. What about the history in these patients? So, most often they have no symptoms, right? Nystagmus is there, the eyes are shaking, it's a sign, we see it on exam, but patients are asymptomatic. However, they can have oscillopsia, shaking of things in the environment, particularly if the nystagmus is in primary position or in down gaze, because that's where we spend most of our time. When we look to the side, we tend to move our head. When we look up, we tend to then move our head, and most of the time we're looking straight ahead and down. But if you have symptoms, it's oscillopsia is the most common symptom in patients with acquired nystagmus, and in congenital, it's decreased visual acuity. You also want to take a history of what medications they're on. There are a lot of medicines that can cause nystagmus, particularly anticonvulsants, sedatives, lithium. Alcohol or drugs do it. And you want to take a family history because there are conditions such as spinocerebellar degenerations that run in families that have nystagmus. You want to ask about other neurologic symptoms, so long tract symptoms, numbness, weakness, arms and legs, etc. Cranial nerve symptoms. So if someone has nystagmus and has a sixth nerve palsy, you're worried about a pontine lesion. If they've got a third nerve palsy and nystagmus, you're worried about a midbrain lesion. So you want to ask about other neurologic symptoms. What about with peripheral vestibular disease? If someone has an acute unilateral vestibular abnormality, they'll have vertigo, they may have hearing loss, they may have tinnitus because it's an inner ear issue, they may have nausea and vomiting. So you want to know about these symptoms. When you examine these patients, what are the goals of the exam? Number one, we want to determine if it's peripheral or central by looking at the pattern. You want to determine, is it jerk, pendular? What direction is it? Is there a null point? You want to do a head thrust test if it's a peripheral vestibular to see whether they've got a normal or abnormal vestibulocular reflex, which we'll talk about when we talk about supranuclear, because that can help distinguish a central stroke from peripheral vestibular abnormality. If you decide it's central, you want to be able to localize the lesion. You want to look for long-standing head turns or tilts, which might suggest an infantile nystagmus, and of course you want to assess afferent visual function. You examine patients in all positions of gaze. You determine if it's jerk or pendular. You determine the direction in each place. You note the amplitude and frequency. You look for a null point, and because there's periodic alternating nystagmus, which changes over time, you want to examine patients for a few minutes. So, what about distinguishing peripheral versus central? So the big situation where this comes in is somebody comes to the emergency room at Jefferson or sometimes at Wills, and they've got acute vertigo and they've got nystagmus. And you've got to say, is it a peripheral vestibular labyrinthitis or Meniere's disease, or is it a stroke? So this is the typical pattern. With peripheral disease, it's horizontal or horizontal and torsional. It's not vertical. It's unidirectional. So if it beats to the right in right gaze, it might slow down in left gaze, but it will not turn and beat to the left. It will stay unidirectional. And it's always a jerk nystagmus. It's never pendular. The typical central pattern, the horizontal direction changes with gaze. So you can look, if you look to the left, it goes to the left beating. If you look to the right, it may be right beating. It may be vertical, so it's upbeat and up gaze, or downbeat and down gaze. And it may be pure torsional. It could be jerk or pendular, but one of the big problems is it can mimic a peripheral pattern. And the reason it can mimic a peripheral pattern is as you enter the brainstem and get to the vestibular nuclei, if you have a lesion right there, it can mimic a peripheral eighth nerve problem. Or you could have a lesion in the basilar artery, which closes off the auditory artery that goes to the ear or goes to the peripheral nerve. And so you could have a central process that gives you a peripheral pattern. So you can be fooled, and you have to take each patient individually and try to make the best decision. You want to look for associated findings such as head turns or head oscillations, which may be helpful. And if you have a peripheral vestibular nystagmus, you should know that it is suppressed by visual fixation and by having a light on. So that patients may come into the ER with acute vertigo, you examine them, you find no nystagmus, and you think they're functional, they're not organic. But if you take away fixation, the nystagmus will appear. And you can do that a couple of ways. The top photo shows somebody looking at the optic nerve with a direct ophthalmoscope in the dim lighting while covering the other eye. So they can't fixate on anything. You take away fixation, and you look at the optic disc, and you see the disc shaking, and you know that there's nystagmus. The bottom picture, are Fresnel goggles. These are goggles with a high plus, say a 20 plus lens in them, so the patient can't fixate. There's a light in them, so you can see the actual eyes very well, and therefore you could bring out vestibular nystagmus. Now, some patients have a history of positional vertigo. So when they turn to just a certain position, then they get vertigo. And typically it's rolling over in bed or getting up quickly into one position. And if you elicit that history, it makes sense to do the Dix-Hallpike maneuver. If you don't get a history of positional nystagmus or positional vertigo, you don't really have to do this maneuver. In this maneuver, you turn the head to the side and rapidly move them down, and you want to see if there's a nystagmus and if they get vertigo. Causes of peripheral vestibular lesions are labyrinthitis or vestibular neuronitis, Meniere's disease, or ischemia in the internal auditory artery. And again, if you have a unilateral peripheral vestibular lesion, the nystagmus is horizontal, rotary, or pure horizontal, does not reverse direction. It's worse when looking towards the fast phase of the nystagmus. The fast phase is away from a destructive lesion, and you tend to fall toward the side of the lesion. So let's take this example of someone who's got a lesion in their left inner ear, a vestibular labyrinthitis, let's say, and so the left ear is not stimulating the vestibular nerve, so the right ear is unopposed. You get a slow eye movement to the left and a corrective saccade to the right. So the nystagmus is opposite the side of the lesion. So let's take a look at this 40-year-old man with sudden onset vertigo and nausea, and we have Fresnel goggles on him, and we see a left beating nystagmus. Okay? Left beating, it's in left gaze, it's still left beating. Without the goggles, you would not see this well, because with fixation it goes away. In right gaze, there's a tiny bit of left beating nystagmus, but much less than in left gaze. As you go to the left, it's more prominent. So a pattern of a right-sided peripheral vestibular abnormality. Take off the Frenzel goggles, the nystagmus is gone. Okay? Typical peripheral vestibular pattern, unilateral. Now let's talk about benign paroxysmal positional vertigo. So this is the only peripheral vertigo situation where you have a vertical component. So this is patients who have brief vertigo, just for seconds, induced by change in head position, such as rolling over in bed, bending down, looking up. They may have an antecedent head trauma. They may have had a viral infection with labyrinthitis, but very often it's idiopathic. And the pathogenesis is either canalolithiasis or cupulolithiasis. There are these little stones that get free and stimulate the hair cells in the posterior semicircular canal. And typically, if you do a Dix-Hallpike maneuver with a BPPV in the right ear, you'll get a counterclockwise nystagmus in the right eye and a counterclockwise and an upbeat in the left eye. And if it's a typical peripheral pattern, there'll be a latency. There'll be a few seconds before it starts. They'll last less than a minute. If you do it again and again, it fatigues. It gets less. And when you go back to the upright position, it reverses direction. Rarely, you can have a central cause of positional vertigo, and in those cases, it's immediate. There's no latency. It lasts more than a minute. It persists. It does not fatigue on repeat testing, and there's no reversal in the upright position. So we will take a look at a patient from Dr. Z, who shared this video with me, of benign paroxysmal positional vertigo. You turn the head to the right. The patient will go down towards the right. We will see a nystagmus after a couple of seconds, and we'll only be seeing one eye actually in this patient, and this will be a classic benign positional vertigo. So what's going on here? Anybody know why this is not playing?
What's the video?
Talking about right here?
No, on the screen.
On the screen itself.
Move the cursor.
Move the cursor where? You talking about down here? Now we go there.
If you click on the actual picture, does it have a play button on it?
Yeah, that's what I've been doing. That's weird. Let's see if these are going. It's interesting. It worked on here. The reason I brought my own computer was because it worked here.
Click. There you go.
There we go. Slow motion. So we see a rotary and upbeat nystagmus, okay? And it'll last only a few seconds. Does anyone know what I did different there that worked?
Click on the picture.
That's what I've been trying to do all along, but okay. How do you treat benign positional vertigo? It's the canal repositioning maneuver. You start with the Dix-Hallpike, then through this maneuver, we won't go over the details, but you should all learn it. You can remove the loose stones and get them from the posterior semicircular canal into the vestibule, and they won't cause the problem anymore. And it's a cure. Now, let's talk about gaze-evoked nystagmus. So gaze-evoked nystagmus is you go to the right and it beats to the right, you go to the left and it beats to the left. This is the most common type of nystagmus that we see, right? And what's the cause? Well, it could be physiologic, and in that case, it's not sustained. It's only there at the end. It's low in amplitude. If you come back to three-quarter gaze, it's gone, and it's symmetric. Pathologic gaze-evoked nystagmus is most commonly caused by medications. So sedatives, Valium kind of things, anticonvulsants, Dilantin, Keppra, etc., hypnotics, or alcohol or other drugs, or structural lesions of the brain. So we're going to now go over forms of central nystagmus. Okay? They come in two varieties. They're jerk or pendular. So we'll talk about these forms of localizing nystagmus: Brunn's, rebound, INO, periodic alternating, downbeat, and upbeat. So here's a 35-year-old man with progressive hearing loss in his left ear. He has dizziness, and he has this large tumor that's not only on the peripheral nerve, but it's pressing on the brainstem. So we're going to get two kinds of nystagmus together. We're going to get a peripheral vestibular nystagmus from this nerve, and we're going to get a neural integrator nystagmus from pressing on where the horizontal neural integrator is. So we see this with large CP angle tumors. You get a contralateral, high-frequency, low-amplitude nystagmus, which is the peripheral vestibular component. You get an ipsilateral, low-frequency, high-amplitude nystagmus from pressing on the brainstem neural integrator. So it's an asymmetric nystagmus, even though it changes direction. And this video, as well as many others, comes from the Neuro-Ophthalmology Virtual Educational Library, the Novell website. The website's there, novell.utah.edu. And this has a lot of videos and lectures and slides on all neuro-ophthalmologic topics that's free and available for your to download and to use for teaching and your own education. There's also at this library, under StatRef, I don't know if you all know about StatRef, there's a lot of neuro-ophthalmology stuff. We have Walsh and Hoyt, we've got this collection, and we also have a new thing that just was uploaded this week called Next, which are neuro-ophthalmologic examination techniques, which is very helpful. So you should make use of that. Anyway, so here's a video from that place, and this is a patient with a large CP angle tumor. You'll see that there's low amplitude, fast nystagmus to the right.
These are peripheral vestibular nystagmus.
And to the left, you'll see a larger amplitude, slow nystagmus, right?
Nystagmus, again, beating in the direction of gaze.
Okay? So you see that it's gaze evoked, but it's very asymmetric. Low amplitude and fast in one direction, high amplitude and slow in the other. Okay? The next kind of nystagmus, so that localizes to the CP angle. The next kind of nystagmus that localizes is the rebound nystagmus. This localizes to cerebellar systems. There's definitely a cerebellar disease here. So there's no nystagmus in primary position when you start out. You look to the right, it beats to the right. You come back to the center, it reverses and beats to the left. You go to the left, it beats to the left. You come back to the center, it beats to the right. So whenever you come back to the center, it reverses direction of what it was laterally. Okay? So here's rebound nystagmus. I am still trying to click on the picture, right?
You're too far to the right.
Oh, I'm seeing on my computer it's on the picture, but there it's not. That's interesting. The mouse is in a totally different position. I am right on the picture here on the thing, and it's not moving here. My mouse is moving all over here on the screen.
Let's escape again.
Escape, okay.
Then click the PowerPoint button.
To click the PowerPoint button?
Yeah, on the bottom left.
How about I do this?
Oh, that's good too.
Now make a pic.
Now make it larger. Okay. So it beats to the right and right gaze.
Now click it. Click it.
Now click it. I'm on it. Now I'm liking it. Terrific. All right. Beats to the right and right gaze. Initially in primary position, there was no nystagmus. Come back. Now beats to the left. Go to the left. It will beat to the left. Come back to position primary. It'll beat to the right. So wherever it was laterally, it reverses when you come back. That's a definite disease in cerebellar systems. Cerebellar degeneration, focal lesions of the cerebellum. Dissociated nystagmus, you're all familiar with. This is an INO. One eye is got an abducting nystagmus, the other one's not doing it. It may reflect an adaptive mechanism to the contralateral adduction weakness. Again, from the novel website, this is Shirley Ray's collection. Here's a patient with MS with a bilateral INO. We saw a patient like this yesterday in NeuroOpht. Adduction deficit in each eye, abducting nystagmus in the other eye. So there's the left INO. The other direction we see the right INO. Sometimes you have upbeat nystagmus in upgaze. Okay? That localizes, of course, to the medial longitudinal fasciculus, right? Periodic alternating nystagmus is a nystagmus that jerks to one side for about 90 seconds, stops for a few seconds, jerks to the other side. 90 seconds, stops, goes to the other side, back and forth, back and forth. It's gaze evoked in lateral gaze. So when you look to the right, it beats to the right. You look to the left, it beats to the left. The alternation is in the primary position. It's due to a shifting null point. So the null point is moving from right to left, oscillating. So if you're on one side of the null point, you beat one direction. When the null point's on the other side, you beat the other direction. And it's a lesion at the cervicomedullary junction, such as an oral cavity malformation, or in the cerebellar system, such as a cerebellar degeneration. Okay? And here's a patient, this is from Dan Gold's collection at the Novel website, a patient with cerebellar degeneration. You have to have patience to examine these patients because you got to wait till it reverses. So it's beating to the left. So as Steve Galetta, my colleague from NYU, says, you go see a patient on the wards, the medical student, the resident, the fellow. The resident says to the attending, there's left beating nystagmus, right? Then the fellow comes out and says, there's right beating nystagmus. Then the student comes out and says, what's nystagmus? So we're still beating to the left, okay? You gotta wait a long time. It slows down, right? But still some left beats. When it slows down and stops, sometimes you see a couple of down beats. I don't think we see that here. And then it's going to start beating to the right. Go through the same thing. This might be the null period. And here we go to the right. Okay? So this is a sign of cervicomedullary junction disease or cerebellar degeneration. Occasionally it's congenital. And the real importance about knowing that it's congenital is that if you're going to do surgery for it, then your surgery is different for PAN than it is for other congenital nystagmus. Downbeat nystagmus. That's downbeating in primary position. It's always worse in lateral gaze. Okay? It's again the same location, cervicomedullary junction or vestibular cerebellum. But it can be due to toxicity from lithium, dilantin, tegretol, morphine, amiodarone, carbamazepine. rarely seen with magnesium deficiency, thiamine deficiency, or B12 deficiency. It's part of some paraneoplastic or other immune-mediated encephalitis, such as the anti-GAD65 antibody syndrome. And occasionally, and quite often, about 40% of the time, it's idiopathic. So here's a case with an Arnold-Chiari malformation, seen right here. And, okay, my mouse is off again. I got to escape. And then open it again,
Yeah, open again.
like that. And am I on it now? Anyway, interesting system. All right, so in primary position, there's very little nystagmus here. You can hardly see anything. Patient's complaining of oscillopsia, but then you put her in lateral gaze, look how it comes out. It's always worse in lateral gaze. Often associated with an alternating skew deviation too. So diplopia in lateral gaze. So she looks to the side and she gets oscillopsia. Primary position, hardly any. Looks to the left, here it goes again. And this is from her Arnold-Chiari malformation. Upbeat nystagmus is a little less localizing, but if it's worse in down gaze, it's typically in the medulla. And when we say it's not as localizing, you know for sure it's in the posterior fossa. It's brainstem or cerebellum. But if it's worse in down gaze, it's likely a medullary lesion. It could be at the pontomedullary junction, it could be at the pontomesencephalic junction, or it can be in the cerebellum. It's seen in cerebellar degeneration, mass lesions, such as tumors, infarcts, MS, etc. One of the characteristic causes of this is Wernicke's encephalopathy. Okay? So here's a patient from the novel website again with Wernicke's encephalopathy. Now, Wernicke's can give you any kind of nystagmus or any kind of eye movement abnormality, but this is one of the classic ones. Pure torsional nystagmus, if it's purely torsional, no horizontal, no vertical component, just rotary, that's usually a lesion in the medulla, and it may be seen associated with an interesting form of skew deviation called the ocular tilt reaction. And so here's a pure torsional lesion in a patient that Matt Thurtell shared with me with a lesion in the medulla. Now, all these forms of nystagmus we saw so far are jerk because they have a fast phase. So here you see the fast phase is going towards the right shoulder. But then there are forms of pendular nystagmus. They could be horizontal or vertical or combined. So if they combine, they could be oblique, circular, or elliptical. It's often dissociated, so that one eye is doing something different than the other. The most common cause of acquired pendular nystagmus is multiple sclerosis. It can be caused by visual loss, so afferent disease gives you pendular nystagmus. It could be toxicity of some medications, stroke, or cerebellar degeneration. So here's a patient with MS with a combination of horizontal and vertical nystagmus. This is elliptical, right? Because it's sort of a larger horizontal than a vertical. And this is from MS. Here's another patient, a 25-year-old man, has a hypercoagulable state and gets a brainstem infarct and has double vision. But 10 months later, while he's in rehab, he develops oscillopsia, and he's got pendular nystagmus. Okay? You see it's a little bit disconjugate, but it's a combination of horizontal and vertical, and it doesn't have any fast component. So what do we worry about when someone develops nystagmus 10 months after a prior stroke in the brainstem? Do we worry about another stroke? So that's typically what people worry about. But this is not another stroke. This is oculopalatal myoclonus or oculopalatal tremor, right? This is a rhythmic 1 to 3 per second movement of the palate, the the eyes, the face, and the larynx, which typically occurs from 0 to 49 months after an infarct involving what's called molar raised triangle, usually the central tegmental tract. And pathologically, something they may ask you on boards and things is you see hypertrophic degeneration of the inferior olive in the medulla. This is an eye movement and a palate movement that persists in sleep. So the clue is you have them look at their palate and it's going the same speed as the eyes. Okay? So it's a pendular nystagmus associated with palatal movements called oculopalatal myoclonus or tremor. And pathologically, you see this hypertrophy of the inferior olive, which is also a sign of transsynaptic degeneration in the nervous system. On an MRI, you might see this lesion in the medulla, and they'll erroneously call it a new infarct. But it's not a new infarct, it's a secondary degeneration. Okay? Another very unusual and rare thing is called oculomasticatory myarrhythmia. So this is a rhythmic, 1 per second, pendular convergence and divergence nystagmus, which is pathognomonic of CNS Whipple's disease. And they always have an associated supranuclear gaze paresis, so they can't move in many directions. So here's a patient. This is, I got my mouse issue again. Okay, we're going to escape and start again. And will it work? Yes. This patient of Shirley Ray from the Novel website who has this convergence and divergence eye movement 1 per second. It's called oculomasticatory because it involves the eyes and the chewing muscles. You see his chin going at the same time of his eyes. So this is Whipple's disease, pathognomonic of Whipple's disease. Seesaw nystagmus is a nystagmus that looks like a seesaw in a park. One eye goes up and intorts, the other eye goes down and extorts, and then they reverse. If it's congenital, the torsional component can be the opposite direction. And this is typically involvement of the diencephalon or chiasmal region. So here's a 33-year-old man who had a pituitary adenoma resected 1 day prior to this video. He has diplopia and oscillopsia. And you see that he's post-op, and you see the one eye go up and in, and the other eye go down and out. And you can imagine what kind of double vision and oscillopsia he has. This is not common, but we see it with lesions of the chiasm. And this is the pendular variety. If you see a jerk nystagmus that's seesaw, then it's in the midbrain. Okay? Most of these patients have a complete bitemporal hemianopsia. So convergence retraction nystagmus is a convergence and retraction of the eyes on attempted upgaze seen with Paranode's dorsal midbrain syndrome. And when we talk about supranuclear disease, we'll talk about this syndrome more, but it includes a lid retraction. It includes an upgaze paresis, poorly reactive pupils to light but better to near, and convergence retraction nystagmus. It's not truly a nystagmus because it's not rhythmic, it's more saccades that are occurring. So here's a patient with a lesion in the dorsal midbrain who we will reset and get to. And what you see is attempted upward saccades, which are slow, there's convergence of the eyes and retraction. Each time she tries to look up, the eyes converge. So it's not truly a nystagmus, but it's called convergence retraction nystagmus. It's a sign of dorsal midbrain disease. And she has a germinoma, patient of Dan Gold's. The final thing we'll talk about is a unilateral shaking of the eye called superior oblique myokimia. This is a monocular cyclovertical oscillation that is not rhythmic. It's more like a tremor. They can present with oscillopsia in one eye or diplopia. And it's idiopathic, but there have been rare cases of a midbrain tumor, so you have to scan these patients. You'll typically have to look under the slit lamp while it's happening to see it, so you often miss it. So this is a right superior oblique myokimia. You see it's sort of like a twitching in the right superior oblique muscle with depression of the eye and intorsion. Monocular, typically benign, typically responds to things like carbamazepine. So just to summarize the localizing types of nystagmus. Periodic alternating, it's the cervical medullary cerebellar system. Downbeat, same place. Convergence retraction, dorsal midbrain. Rebound cerebellar system. Oculopalatal myoclonus is in molar raised triangle, which is the inferior olive, the dentate nucleus, and the red nucleus. Seesaw, paracellar or chiasmal, and midbrain. Brunn's nystagmus is a large CP angle tumor, and when we talk about supranuclear, we'll look into ocular flutter and opsoclonus, which will localize to the omnipause neurons, and we'll talk about that next time. So I thank you for your attention and glad to take any questions. Good. We're all sufficiently confused. Thanks.